Hi everyone. Oh, lights are a bit blinding. It's a pleasure to be here and a pleasure to follow John, who I knew a long time ago back at the Freeman Hospital, back in the 90s, and it's great to see you, John, and hear you talk. And some of the improvements that John has made and the pathways that he's been looking at kind of reflect a little bit in how we've approached needing a pathway changes to be able to get innovations into pathways when we've been looking at the blood culture pathway. So to introduce myself, let me just, does that work? Yes. Right. To introduce myself, I'm Jane Freeman, and I am from Leeds General Infirmary, but I am actually employed by the University of Leeds, and in my other role, I am a clinical lead for AMR Diagnostics at NHS England, and that's actually the hat that I'm wearing today. I'm sure many of you wear lots of different hats, and that's what I'm doing today. So today, I'm going to outline some of the work that we've been doing at NHS England in the AMR Diagnostics team to examine how we do blood cultures against the existing guidance, what we found, and the improvements that we're recommending. So, why are blood cultures important? Well, I'm sure that none of you would be here today if you didn't think blood cultures were important and if you didn't appreciate the answer to that question. Put simply, blood shouldn't really have much in the way of bugs in it, and when it does, that can mean an infection, and possibly a life-threatening one. So we really need to find out what's in there and how we can treat it. And the reason it's important that we do this is that in addition to clinical symptoms, blood cultures help us to diagnose some important and potentially life-threatening infections. Some infections of the bloodstream, but also some infections that are focused elsewhere, like, for example, pneumonia, meningitis, osteomyelitis, and others that can lead to the life-threatening condition sepsis. So sepsis, as I'm sure many of you know, is an insidious condition, sometimes known as the hidden killer. And the reason for this is that initially symptoms can look like other conditions like flu or chest infection or even gastroenteritis, and that makes sepsis pretty difficult to spot. And even some of the more indicative symptoms like confusion or slurred speech, muscle pains, breathlessness, not passing urine or mottled skin or rash, aren't exactly diagnostic. Behind these non-specific symptoms, the body's immune system is beginning to overreact to infection, going on to injure tissues and organs and leading to shock and multiple organ failure. So it's a life-threatening emergency, and it causes a significant number of deaths around the UK and around the world. In the UK, there are about 48,000 deaths from sepsis each year. And that as a result of 245,000 cases. That's from the Sepsis Trust. And it's worth highlighting as well that there are particularly vulnerable groups. So I've highlighted here that sepsis causes a quarter of maternal deaths in the UK. And even when people do recover, they can be left with some severe long-term difficulties and disabilities due to the damage that's caused by the disease. So aside from recognising the symptoms, aside from increasing recognition of the symptoms clinically that I've just outlined, with campaigns like Could It Be Sepsis from the Sepsis Trust, there's been considerable development in the management of cases through initiatives like Sepsis 6. One of the key components of Sepsis 6 is taking blood cultures. And they are actually a relatively simple test, but one with the ability to detect a wide variety of organisms. And by taking them as early as possible, in line with the Sepsis 6, patients are on a pathway to timely and effective treatment, and hopefully on the road to recovery from a major and life-threatening illness. Treating sepsis is always going to be a balance between managing a life-threatening condition and avoiding the use of unnecessary antibiotics. Timely, appropriate and effective antibiotics are a major pillar of sepsis treatment, But at the moment, most antibiotic treatments for this condition are empiric. It's based on the best evidence in the literature, and it covers the patient for most of the pathogens that will likely be causing the infection, but it's not based on the actual pathogen that's causing the infection in that individual patient. And we know that between 19 and 34% of patients with bloodstream infections are not on an effective antibiotic treatment. We also know that inappropriate antibiotic use is a driver for antibiotic resistance, so why aren't we able to target our treatments and avoid using so many broad-spectrum antibiotics? As John's talk amply demonstrated, culturing bacteria and fungi from specimens, and particularly from blood, takes time. And while most positive blood cultures will flag up between 8 and 12 hours, they can take longer. And in any case, 8 to 12 hours is still a significant proportion of time to wait for an accurate result for a patient with sepsis. Sepsis patients don't have time to wait. It's not possible to wait for a blood culture to start antibiotics, so we must start with those empiric treatments and then focus, once we get the results, switching to a more targeted treatment or stopping altogether if antibiotics are not warranted, or escalating if that's necessary. How can we do this better with the tools that we currently have at our disposal? Sepsis and antimicrobial stewardship really are two sides of the same blood culture pathway coin. Improving how blood cultures are processed by improving accuracy and the time taken to diagnose sepsis will also benefit antimicrobial stewardship ambitions. If we can get to an appropriate antimicrobial prescribing decision faster, we can save the lives of people with sepsis, but we can also improve the health of the population by reducing AMR and protect the antimicrobials that we do have for future generations. So optimising that blood culture pathway will allow us to tackle both sides of that coin, sepsis and antimicrobial stewardship. It's really easy to view a diagnostic sample in isolation, sample test result, but that doesn't really reflect actually how illness is or how patients experience it. Diagnosis begins earlier than that, with the presentation of the patient, with the diagnostic test being a key element of the many steps that the patient will take, hopefully, towards the right treatment and recovery. And that's why we describe it as a pathway, with the many stepping stones that are involved between patient, test and treatment. So the UK Standards for Microbiology Investigations set out how specimens are taken, tested, analysed and reported for blood cultures. These are currently under review. The last guidelines having been written in about 2014. And when the review is complete, they'll be part of a syndromic diagnosis document around sepsis and systemic or disseminated infections. But these guidelines have been in existence for about 8 years, and they still set out the major parts of the processes. And there are 3 key elements to the blood culture pathway that this guidance covers that I'm going to talk a little bit about. So these 3 elements that I've outlined here are the pre-analytical, the analytical and post-analytical phases, or to translate them into something a little bit more digestible, sample collection, sample processing, and the patient management that's then informed by those processes and the test results. Now, you'll see across all of these that there are 2 real tangible ways that we can improve patient treatment, and that's by taking the right amount of blood and the time involved in it. So let's look at this a little bit further. So, as most of you will probably know, a blood culture set is a combination of 2 blood culture bottles, one aerobic and one anaerobic, because not all bugs like the same conditions to grow in. We need both of those present in a set so that we can detect organisms that don't like to grow in exactly the same conditions. Otherwise, the test is not going to be as accurate as we need it to be because we haven't given them the right conditions to stick their head above the parapet and be detected. The recommended volume of blood that we need to provide the most accurate diagnosis that we can is about 40 mils and spread over 2 sets. So that's 4 bottles, 2 aerobic, 2 anaerobic. This is evidence-based, and the evidence has been there since the 1970s. but it has also been re-evaluated periodically and pretty recently, taking into account the advances that we have in blood culture testing with continuous monitoring systems that allow random access. The figure on the left, which is shamelessly taken from the bioMerieux blood culture booklet, shows the increase in detection sensitivity when the volume of blood drawn and analysed increases. And the one on the right from Henning et al. In 2019, I think, shows that the odds of detecting a positive patient increased by 13% for each millilitre of blood additionally drawn, with the sweet spot of those error bars there being around 10 mils per bottle. And really this is a scientific evaluation of common sense, isn't it? You take more blood, the more likely you are to find something. The trick, of course, although it's actually not a trick, it's what the science tells us, is taking enough blood to get diagnostic benefit. The guidance in the UK, based on the evidence, is 40 mils across those two sets of bottles, and it's been there for a number of years since 2014. So turning up the volume, following that guidance and making sure that we do that is a really important part of the blood culture pathway improvements, and it will help us reach an accurate diagnosis for patients with life-threatening infections while reducing antimicrobial pressure through better informed prescribing. So the next kind of key part of it is time. And time is crucial when you're diagnosing a potentially life-threatening infection, isn't it? But it's also crucial in terms of antibiotic resistance by getting to the most appropriate antibiotic treatment as fast as possible. So the decision about when to take a sample for blood cultures is a clinical one. It's made by the people on the ward according to symptoms, etc. But once those blood culture bottles are filled, the clock for many of us as laboratory workers and people who are working as scientists and medics, the clock starts ticking. We need to get those blood culture bottles to the lab as fast as possible and on the analyzers. The scientific evidence tells us that the detection of microorganisms is significantly earlier, the faster it gets onto the analyzer. And that's why the guidance recommends that the time from taking the sample and putting it into the blood culture bottle to loading it onto that blood culture system should be no more than 4 hours. Some countries have it as a shorter period, as 2 hours, but in this country, it's within 4 hours. And there are simple reasons for this. Some organisms will start to die the longer they're out of their optimal conditions, so that reduces the amount of organisms in the sample, so then that takes longer for them to grow and longer for you to detect them. Some organisms, by contrast, particularly those that are fairly hardy and can be found on the skin, are fairly happy outside the body. They don't really, need much in the way of help to survive and grow. If they happen to contaminate the blood culture sample when it's being taken, they can survive pretty well. And this can lead either to a false positive or masking of the true pathogens in the sample. So we really need to get that blood culture sample to the analyzers and on as fast as possible. So blood culture pathway improvements, why do we need them and how are we going to do it? So before I joined NHS England and a few years before the pandemic, NHS England undertook a survey of blood culture practices to just find out where we were and exactly what was happening in trusts up and down the country, to build a picture of how what we were doing maps onto that guidance and what's happening. And then looking at it and identifying if and where improvements could be made that would lead to patient benefit. And then once we had the results, developing recommendations and kind of strategy of implementation for how it could be delivered and monitored going forwards. So the survey went out across the UK in 2018-19, and we got 158 responses across England and the devolved nations. District general hospitals accounted for the majority with 90 responses, but we also had 58 teaching hospitals and we had 9 specialist hospitals. And of the 158 responders, 124 of them had on-site microbiology laboratories. So that gives you a picture of who we were looking at. So the SMIB 37 microbiology standard that I mentioned earlier puts audit of the blood culture pathway right at the heart of this process as a key requirement. But despite this, when we looked, 41% of the survey respondents told us that they never audited their blood culture pathway at all. And of those that were auditing, most had audited within the last year, which was 43% of respondents, but only 25% of labs were able to provide complete data supporting the SMI B37. So if we look a little bit closer at that, this is data from 13 hospitals who were able to give us data about how long it took for their samples to get from the patient onto the analyzer. So the horizontal axis shows the kind of individual hospitals that are just numbered, and that vertical axis shows the percentage of samples. So the SMI B37 recommended target of less than 4 hours is indicated by the blue colour. And we can see that there really is quite wide variation here, from less than 5% being put on the analyzer within 4 hours in one place, contrasting with 80%, possibly more in another. More worryingly, in some hospitals, there were only 40 to 50% of blood cultures getting onto the analyzers in 12 to 24 hours, which is quite a long time. And when we looked closely at how blood cultures that were delayed, that were taking a bit longer to get onto the analyzers, were stored, we found that 40% were left at room temperature, while 12% were placed into an incubator, and that's against the guidance and the manufacturer's recommendations too. So as I said earlier, the evidence and the guidance indicates that 2 blood culture sets should be taken, each with an aerobic and an anaerobic bottle. But only 17 of the 148 sites who responded to this particular question reported using 2 blood culture sets, and that's about 11%. The majority, that's 129 sites, about 87%, were using a single set with an aerobic and an anaerobic bottle. But there were 2 sites that were only using a single aerobic bottle for their blood cultures. I said earlier that volume is critical to accurate and timely detection of pathogens in blood cultures, but while about 12% of the hospitals that we looked at and were actively surveyed were actively measuring the volumes of blood in their blood culture bottles at varying intervals, 88% had never measured them at all, and so were not able to know whether the correct volumes of blood were being put into bottles. And so, having performed and analysed the survey, NHS England decided on 4 key recommendations. And the summary recommendations are available on the NHS Futures platform. You can access those. So the recommendations firstly were the guidance around best practice and what we should be doing with blood cultures is already out there. We need to build on the adoption of this more widely. Secondly, in order to do this, we need to monitor what's going on, where things are working and where they're a little bit more difficult, and to be able to help the people who are not managing to achieve the recommended targets. We recommended a change in culture so that antimicrobial stewardship and AMR become a kind of core part of clinical leadership and governance within trusts. So you get that board level buy-in to help support the changes that we need to give the best outcomes for the patients that we serve. And because we need to monitor that, we need to improve the regulation and the accreditation around blood cultures. So changing it from just being a pathology test and starting with the sample coming in and the result going out, changing it to a pathway approach from the ward to the lab and back again. And to do that, we need to engage a number of different bodies, which I'll talk a little bit about later. And because the pathway recommendations, because it is a pathway, recommendations 3 and 4 are particularly important in building recognition that the blood culture pathway must have a team approach. Lots of people are involved in the blood culture pathway and they've all got a role to play. And it's really important that we recognise that to get it to work properly. I think it's important to note that we do have a number of resources to support trusts trying to improve their blood culture pathways. And they are available on the NHS Futures website, supporting the findings and recommendations. we do recognise that implementation is not necessarily going to be easy for everybody. Because if it was, then everybody would be doing 2 sets of blood cultures and getting them on the analyzers in 4 hours already. So we know that it's not always going to be easy. So we're building a suite of case studies of how some trusts have managed to make improvements and convince their boards to invest in additional staff or invest in additional equipment. And we've also got a toolkit there that has our audit tool in there and instructions for use. And more about that a little bit later. So to tackle the improvements and change the culture, we're taking a multi-pronged approach. The first, as I've just mentioned, is that board-to-ward approach, communicating with everybody who is involved in the pathway, not just pathology, and including the senior leadership within trust. This is a top-down and a bottom-up approach, bringing teams together to review the KPIs and really make a big difference in how we're performing. So a pathway is just that. It's a number of stones that are held together by mortar. And it provides a way to get from A to B. And if the mortar crumbles or one of the stones is missing, it can't work effectively. And so it is with the blood culture pathway. The stones are the various groups of staff that are involved practically and clinically in taking the sample, transporting it, testing it, reporting the results and giving the treatment to the patient. It's a wide group of staff that are involved and each role is important. So we really need to ensure that there is appreciation of and that they appreciate how important their role is in that whole pathway. A porter is not simply moving a sample to transport. They're ensuring that the patient gets their treatment as fast as possible. Transport staff are not simply ferrying a sample somewhere, they're providing the conditions and the speed necessary to ensure the results are as accurate and fast as possible. They're part of a very important clinical pathway, playing a very important part in patient care. They are the stones in the pathway. And if the staff groups are the stones, then the mortar that holds them together are the trust boards. They allow them to function. The boards are able to give their backing and support for the optimised pathway and support all the elements to deliver the best care for the patient. So if we're enlisting their help in the blood culture pathway, in staff education and resourcing, and a change in the thinking around how we do blood cultures from a pathology test to a board-toward pathway. We also need to get education and training right, and in a way that reflects that wide group of staff that I've kind of just talked about. It needs to be relevant, easily available, and in multiple formats. And so to this end, we've, as well as the information available on the Futures platform, we're gathering those case studies from trusts who've had success, and trying to buddy them up with trusts who are finding things a little bit more difficult to take advantage of that good practice. We've also been working with BSAC to develop targeted e-learning courses for each of those different staff groups. And of course, should you wish to do them all, you can do and learn about the other elements of the pathway you're involved in. And we've also worked with them to design a series of posters, a suite of posters that is available on the Futures platform for use. You can download those and use them. And that's focused on the volumes and the time and the different parts that people play in that pathway. So kind of highlighting that. If we're going to get this right and keep getting it right, then we need to have everybody engaged and contributing, and that includes industry. The manufacturers of the analyzer and the bottles are part of the diagnosis of sepsis and other infections that the blood culture pathway serves. We need their involvement, we need your involvement and expertise to ensure that our existing and new staff are trained and supported to use Analyze properly. Updates to current tech and the introduction of new tech all need to be supported so that we can take advantage of them to continue to provide best care. Industry are the diagnostic innovators. They are constantly looking to optimise and automate their analyzers and make improvements to keep their products competitive. We, as the users of those products, need to communicate the needs that we have to industry so that we can work together to meet those needs effectively. We need to be involved in that process of innovation so that it's more collaborative. And lastly, if we're to make the improvements to the recommended number of blood culture bottles, we need to make sure that the supply chain is there. And we need to make sure that industry can help us with that, to help us react to the improvements that we hope we're going to make over time. So we talked about how we're going to support it. How are we going to monitor it? Well, first of all, the 22-23 NHS standard contract does refer to improvements in the blood culture pathway specifically. And this should sharpen focus and help with engaging board-level support for these improvements. We're also developing ways in which data is reported and collated so that it's of the most use possible. So this will be facilitated at regional level through the ICSs and ICBs, allowing the data to flow back to trusts to allow us to identify good practice and facilitate that buddying up and also benchmarking. And it'll also flow up to a national level so that it can be monitored to gain a bigger picture. And it will allow us at NHS England to be able to find out where we need to target support, where we can help. And then accreditation and regulation. Well, we need to see the whole pathway embedded in assessment frameworks, both in UCAS and CQC. So that ensures everything is covered, not just what's happening in the pathology laboratories. And as we've said, the pathway includes many staff and many steps across each trust. And in order to support these, we need to monitor how well things are going, how things are working, and endorse that good practice through the regulation feedback mechanisms that we'll be developing with UCAS and CQC. So that's in development. And in order to pull these assessment frameworks together, make sure they work in harmony, we are working with both UCAS and CQC assessors to provide training and information and discussion about what should go into the frameworks and what to assess. Crucial to this is the data that we collect as part of our monitoring processes. So we have developed an audit tool to help us monitor and benchmark, and our regional AMR leads and teams have worked to develop that, along with an audit plan to ensure that that data reflects the fluctuations that we see in blood culture testing in the lab and what impact that might have. Audit used to strike the fear of God into me. I think, first of all, it's important to say that the National Blood Culture Survey was done between 4 and 5 years ago. And it's fair to say we've been through some significant changes as a world, if nowhere else, due to that certain virus that we won't mention. So while we know that we need to get to 2 sets of blood cultures with 8 to 10 mils in each, and on the bottle, on the analyzer within 4 hours, we need to look again 4 to 5 years later to find out where trusts are now. How many are now achieving this and how much at the time? We need to benchmark where we are before we can move forward to an optimum pathway. So I know we have had, feedback. It sounds frightening to move to, a place where you're not already, perhaps for some trusts. We don't expect that to be an overnight transformation. It's a process to move towards. So the audit tool we've developed is available for use now on Futures. You can download it and look at it. And we consulted with some of our regional teams to come up with kind of a plan that will cover the scenarios in labs. So that will be kind of 30 bottles on a Monday morning to find out roughly what's happening over the weekend, 30 bottles on a Wednesday afternoon to cover the midweek activity, and 30 bottles on a Friday for that slope into the weekend. That's the minimum. If you have, times in your lab that you feel need a bit more investigation, you can do more than that. That's absolutely fine. That's the minimum. The form focuses on the volume of blood collected over bottles and sets and how long it takes from collection to getting on the analyzer. While there are fields for data, they are colour-coded to allow you to remove those patient identifying details before you kind of pass those on to other people, so the GDPR implications are kind of covered there. So I've spoken about how we recognise that it can be a bit difficult. So I hope that by doing this audit process, we will be able to identify who's got some really good stuff in place and who is perhaps struggling a little more, and try and work with them to identify how we can help to get those improvements in place. And as I said, Case studies are also being collected and will be put on the platform so that you can look at those yourselves. We will be monitoring that national progress, that national picture, to see where we are and see where we can help. We need to make sure that whatever innovations and improvements we recommend are delivered well. And while I don't want to dwell on this particular slide too long, it shows that the national, regional and local approach that we're taking with the 4 pieces of the jigsaw puzzle. So it's not just diagnostics on AMR diagnostics team on their own. We are very integrated with IPC and prescribing and working in towards those integrated care systems who also have AMR leads within them. And the ICSs have reduction of AMR infections as a key priority within their remit. And I hope that they will bring that continuity and broad reach that we need for diagnostics in general across various healthcare providers in the regions. So the regional teams will also work with the local pathology networks and quality teams to feed back locally to trusts so they can act on the data and gathered and do the benchmarking, but also to us as a national team so that we can reevaluate where we are, where we're going, how we're developing towards improvement and highlight that good practice. So this slide is quite a nice, I didn't make it obviously, a nice slide to summarise all those kind of elements in the blood culture pathway. It's a multidisciplinary effort within the trust that perform them and more broadly outside of that too. All the stakeholders have a part to play, all supporting each other to make them. The benefits are huge, both to each patient who has a bloodstream infection and their families and carers, and to our wider society by reducing the development of antimicrobial resistance with faster targeted antimicrobial treatments for these patients. So I sort of want to kind of just leave you with these 2 posters from our suite talking about getting it right every time, getting the volumes right, getting the times right. And with the picture of everybody, you know, lots of people, the 4 people there, all involved, all playing their part. Speaking of which, I really want to recognise while I'm here the significant work of Mike Weinbrunn, who did a lot of work on the blood culture pathway and previously led it, and Priya Pillai, who worked with him as the project manager and still works as the blood culture pathway project manager. They did so much work on the survey and the analysis and developing the many support tools that we have. And without their hard work, we wouldn't be in a position to make the improvements that we want to make. So I will finish by leaving you with this slide. If you've got any questions or you want to get in touch, then my email is there, and also Rosemary Stevenson, who is the programme lead for AMR Diagnostics. There's the link to the Office of the Chief Scientific Officer's future platform, where you can find those blood culture audit tool and bits and bobs that I was talking about. And more generally, there is the AMR programme on the Futures platform as well, if you want any more information on the more general work that we're doing. So I'll leave it there.